can you see the free flow of cerebrospinal fluid? Sendil, are you able to see that? Yeah, okay. So now, I am attaching a syringe. This contains 0.5% bupivacaine. Injecting the drug inside. Decided to give him, he's a young adult male, and the surgery might last for about 60 minutes. So I'm giving about 2.6 for him. I'm removing this movement. I wanted all of you to. Sendil, are you able to clearly visualize this movement?
Yes, sir.
This is the unlock, and this is the lock. So once you lock it, there is a great stability of the spinal needle over the epidural needle. So this is the most important advantage which I wanted to demonstrate. So I'm removing off the spinal needle out. And I always use, there is a question of whether to use a test dose or not. But I'm using 3 ml of 2% xylocaine adrenaline here for 2 reasons. Very occasionally you see when it goes into the epidural plexus, you will see a tachycardia. But more importantly, also to help us to produce a hydrodissection so that you create a potential space for your catheter to go inside easily. Now I am attaching the introducer, which is a part of this set, and I'm going to thread the catheter in. So I've introduced about 14 centimeters inside, removing the epidural needle out, and this is a specially designed latchet. So the advantage of this is it really is got a mechanism where it can fix your catheter very, very well. And see, this is very good. So you cannot, it doesn't come out easily. This is one of the problems with several epidural sets. Here it's firmly fixed. And if you want to open it, it has to be opened only by an expert so that accidentally people don't remove it. So the way you do it is, can you see this small curvature here? The nozzle of the syringe will fit into this and you open it out like this. Sendil, is it clear?
Clear, sir.
Yeah, okay. So now I'm closing this. So I've removed the air from the filter, connecting the filter to the epidural catheter, and there is a free flow. So I'm going to fix the catheter now. Would like to show you what material we use to fix the epidural catheter. One of the biggest challenges is when you decide to keep this epidural catheter inside, especially in countries like India, where sometimes the temperature goes very high and the patient starts profusely sweating. It is important to take this into consideration while fixing the epidural. So, are they coming in? So here is a fixation, Tripi coming. There is a, if you see, it's an impregnated fixator with cotton inside. So any secretions can be absorbed by this. So then surrounding that you have the plaster, which fixes it very well to the skin. So the biggest advantage is this acts as an absorbent of all the secretions that come out of the puncture that you have made. Sometimes it's the small little bit of ooze is there, so all that will be absorbed by this pudding. Yeah. So I make a small loop while fixing the epidural catheter. So now we will remove. This is a very good so can you see this? And then one more thing which I want, one more thing I wanted to show you is we use this plaster to fix. It has got multiple pores inside, so it can breathe. So the sweat that is formed here evaporates, so there is no layer of sweat is between the skin and the plaster. So the ability to retain it inside becomes much better. So we have completed the combined spinal epidural, and now we will make the patient lie down. This patient was very cooperative. So here I would like to just emphasize only a few points. I just wanted to first show you this epidural needle and the spinal needle. Then I just wanted to show you that there are serrations in this and corresponding serrations. So it has to, the serrations have to go over the serrations there, and this white dot has to go clockwise. So you know there is a firm fixation, absolutely firm fixation. So all the drug that you inject through the spinal needle enters the intrathecal space. And if you see here, you see the spinal needle that has emerged out of the epidural space. So, Sandil, was that clear?
It was fantastic, sir.
So also wanted to tell that the intrathecal space that we reach, the depth of the intrathecal space in which the CSF circulates is about 3 to 4 millimeters. So it's very important that when you inject the drug, you do not dislodge the tip of the spinal needle from the epidural space. That's why it's again very important to have a locking mechanism so that there is no movement of the spinal needle inside the epidural needle. So this completes the procedure of combined spinal epidural, and always it's been a question from several doctors that suppose you have done the combined spinal epidural, you have injected the spinal drug inside, but if you are not able to pass the epidural catheter, or when you pass the epidural catheter, you hit an epidural venous plexus, it becomes a bloody tap, what should you do? Whether you should abandon doing an epidural procedure, because they have two things in their mind. Number one, if the drug gets fixed up because you have already injected the spinal, and if you are taking time to introduce the epidural catheter, does it mean that it's going to become a saddle block? The answer is, if you see the pathophysiology and also the pharmacodynamics of what happens once you inject the drug inside, it has got 3 phases. And the minute you give the drug, it gets diluted in the CSF. Then it gets distributed, and then it gets fixed. It has been found out that if you do a CSF analysis, even after 20 minutes, 50% of the drug is still unattached to the receptors. So which means you can take about, tell yourself that you have about 15 to 20 minutes to perform your epidural quietly and calmly. So you'll be able to accomplish it very soon. But if you're in a great hurry thinking that you should do the epidural in within 2 to 3 minutes, it might not really work because it will put tremendous pressure on you. So my message is, when you do a needle through needle technique, when you have given the intrathecal drug, you need not, even if you are not able to pass the epidural catheter in the first instance, or if it's a bloody tap, tell yourself that you have got 20 minutes more to do the epidural, and again quietly and calmly you can recite it if it's a bloody tap, or you recite it again if you're not able to pass the catheter. 2 reasons why you can't pass a catheter. Number one is probably you're not in the epidural space. Most of the times this is the cause. If you're not in the epidural space, then you will find it difficult to pass the catheter. So once you're in the space, the catheter flows in freely. So this makes the first case combined spinal epidural. Are there any questions, Sandil?
Any queries you can ask Dr. Pavan?
If there are no questions,
So one of
yeah.
the doctors mentioned.
Yeah.
So you prefer 16 gauge 2E or 18 gauge? I saw you were using 18 gauge.
Hello?
Yeah, 18 gauge 2E you use regularly?
Yeah, 18 gauge 2G we use regularly. We have 16 and 18, but I prefer to use an 18 gauge epidural.
Any specific reason?
The reason being, if you see the two gauges and the catheters inside, with this catheter, we don't have any issues. The blockages are very less. There is no issues with it. But the 16 needle is, naturally, it is slightly more bigger than the epidural needle. In spite of local infiltration, I've seen that when you introduce, I think it produces more tissue trauma and more discomfort to the patient. So I always prefer to use the 18 gauge.
Hello.
Yes, sir.
Pramod here.
Yes, sir.
What are the chances of epidural advancing when you are locking the spinal needle?
It won't happen, sir. It won't happen. When you're locking the spinal needle, whether the epidural tip will get advanced more and maybe it will produce a dural puncture. Is that in your mind? No, it's a very gentle procedure and it's a sideward movement. It's not a forward thrust on the epidural needle. It's a clockwise rotation and fixation. So it normally doesn't happen, sir, except that I think if the hands are a bit shaky or something, but it's only a sideward movement. So I think it's usually doesn't happen and I've never noticed it.
So if you get very little blood through the catheter,
Yeah.
and once you flush it, after that on aspiration you don't get blood. So what's your approach?
This is something sometimes which happens clinically. This is a possibility. So when this happens, there are two possibilities. One is it could have been a small trauma which produced some blood to ooze out, and the catheter happens to be close to that ooze, and when you aspirate it comes, but it won't be a free flow. But if you are in an epidural venous plexus, then there will be a free flow of blood, and you surely know that you have to resite. But on occasions where only 2 to 3 ml comes out and there is no free flow, you inject a xylocaine adrenaline and see if there is a rise in heart rate. If there is no rise in heart rate, then you are sure that it is probably a collected blood. But it's also important that you use the xylocaine adrenaline which you give is number one to find out whether it's intravascular. Number two is to flush off the tip of the epidural catheter. Otherwise it will get blocked when the blood comes inside. And when you want to use it later, you won't be able to use. So this is how we manage for this. So thank you very much, and Dr. Silamban is ready to show you.
Sir, I think you still have a question.
So one.
Yeah.
Yes,
Yeah.
sir, go ahead.
Yeah. Sir, good morning.
Good morning.
Sir, any other catheter fixation technique? I mean, because we are finding it very difficult with this kind of technique to keep the epidural catheter in place for 72 hours.
Okay, sir.
especially in DHR and TKRs.
Yes, sir.
I mean, the technique you suggest.
Sir, did you see this fixation, sir, the material that we used? Did you see the material that we used for this fixation? In fact, we used to have these issues when we were using the normal plasters, but this is a very good product. As I said, this is coming from BNS, and we are using it for several years now. As I showed you, this has got pores. One of the biggest reasons why we are not able to keep it in place in India is, I said, is the sweating.
Sweating.
So here if you see, this is a very good, very good one where it has got pores in it. And these pores results in evaporation of all the sweat that you have, and it doesn't actually get displaced. In fact, it's slightly difficult to remove this. So I think you can adopt this plaster. It's produced by BNS Medical. We have found it very good to retain the catheter inside. We don't do tunneling for our epidural. There are some institutions which we do tunneling for the epidural catheters, but because we find this fixation very good, we don't do tunneling in our patients. So thank you very much, and we go for the next case.
Thank you, sir.